In today's video, we'll be covering some PYQs from INASS in the subspecialty neuroanesthesia. We'll directly go to the questions. First question is, a patient undergoing posterior cranial fossa surgery. The most sensitive monitoring strategy for detecting the venous air embolism is. See, this is the most common question asked in every session of INASS or NEET-SS. The most sensitive strategy for detecting VAE, the most specific tool for detecting VAE, which can detect VAE better. So these are different types of questions. So in this setup, the surgery is in the posterior cranial fossa, and the choices are ETCO2, TEE, IBP, SJVO2. So we can eliminate the choices one by one. So this is a posterior cranial fossa. They are not opening the heart to see the epicardial echocardiography, etc., etc. So the answer will be TE. So if you are putting T in a patient, and you can visualize if any venous air embolism is present in the RA or SVC or IVC during posterior cranial fossa surgery. If you are opening on the heart and doing, then the better answer will be your epicardial epicardial echocardiography. And sometimes the precardial echocardiography also will be given as choice, but we know that the RA and the venous structures are usually visualized better in the transesophageal echocardiography compared to the TTE. So the next question, which of the following agents is commonly used to prevent vasospasm following aneurysmal subarachnoid hemorrhage? The options are phenytoin, nimodipine, mannitol, propofol, dexamethasone. So usually the drugs given in the choices are used in a patient during the perioperative period for managing the subarachnoid hemorrhage, for decreasing the BP, controlling the edema, and so on. So, but which agent among this is used to prevent vasospasm? So the answer is B, nimodipine, and it is a class 1 level of evidence A that oral nimodipine should be administered to all the patients with aneurysmal SH. So what is the most common presenting symptom of a ruptured cerebral aneurysm? Seizures, thunderclap, headache, loss of vision, hemiparesis. Noted this question was asked in my NEET-SS exam during 2024, and the answer is thunderclap, headache. Although all these symptoms, seizures if there are any cortical problems, and loss of vision and hemiparesis, all this can occur depending on the different types of aneurysms, and if it is ruptured, these things can happen and the patient can present with these symptoms. But the most common presenting symptom is your thunderclap headache. Next question, which of the following intravenous anesthetics is contraindicated in patients with intracranial hypertension? So your neurosurgical patients will have intracranial hypertension, and which of these IV anesthetics is contraindicated? 1. Propofol, B. Ketamine, C. Fentanyl, D. All of the above. So the answer is obviously ketamine. Any first semester anesthesia PG student can answer this. Ketamine increases intracranial pressure. But if you are getting some things like this, all of the above, then you should be vigilant about it. Mostly if you are given the choice all of the above or none of the above, you should reconsider your answer one or twice. Next question, the cerebral blood flow autoregulatory curve, that curve shifted to the right by A. Hypoxia, B. Volatile anesthetics, C. Hypercarbia, D. Chronic hypertension. So if your neurophysiology is strong, this question is a cakewalk for you. The answer is chronic hypertension. So this is the CBF autoregulatory curve, and the buffer region is from 60 to 150 mmHg of the map. If it falls below that, then your CBF autoregulatory curve won't work. And in patients of hypertension, this curve and this buffer region is shifted to the right since their usual hypertension are more than the usual normotensive patients. So you should be more vigilant in monitoring the blood pressure of these patients intraoperatively, because if you are giving hypertension to a patient who is normotensive, then the CBF autoregulatory curve can manage and there won't be any cerebral ischemia. But in a patient with chronic hypertension, even a little bit lowering of the map, not even till 60, even before like 80, 90, if it had shifted to the right, then the cerebral ischemia can occur early in these patients. So intraoperative monitoring should be vigilant in these patients. Thank you.